Assalamu alaikum. Welcome everyone on board. Uh, Yesterday I couldn't take the class. We will continue from where we left day before yesterday. So the first question here is a 45-year-old man who has undergone multiple spine surgeries in the past. So there will be chances of chronic pain or post-surgical pain because of multiple procedures. He is on 80 milligram daily of slow release morphine for the past year. He is asking for an increase in his medication. Which of the following most appropriately describe the patient's opioid therapy? He is on a very high dose of opioids. So there is no upper limit on the efficacy of opioids. No, there is dependence. Respiratory depression is a significant risk at this dose. Hyperalgesia may develop with increasing dosage. This is one reasonable answer. Constipation is usually resolved after 1 year. Levels of serum ACTH may be increased. I don't recall what's the relationship with the ACTH. I think there is some effect on immunity. ACTH, I don't know, remember what is it. So let's see what is the answer because this is wrong. Respiratory depression and I think other side effects have some tolerance. Constipation, I don't think so. It developed tolerance. Let's see the answer. It's hyperalgesia. May develop with increasing dose. Opioid-induced hyperalgesia occurs when pain is uncontrolled despite increasing use of uh, long-term opioids. The use of opioids has commonly been described uh, without a ceiling in cancer pain and palliative care. But in this clinical picture is inappropriate. The use of opioids in non-cancer pain is becoming recognized as ineffective and potentially harmful due to its suppression of immunity. So immunity is depressed, as I told you, and hormonal systems. So opioid can act directly on this HPA axis to reduce GnRH uh, and LH as well as gonadal testosterone. Opioids also reduce ACTH. So they don't increase, they decrease. Respiratory depression is not observed at stable doses of opioids administered long term. The constipating effect of opioids are long term and do not resolve. So opioids based, I think this is with reference to the effects on the receptors, on the various receptors. So opioid-induced hyperalgesia is the which can occur in this increasing dose. So this is wrong. Respiratory depression will not occur. Constipation will still occur, and ACTH will decrease. Okay. That also leads to the concept of opioid-free anesthesia, which is our future modality. Still not commonly accepted, but I would say that opioid-free anesthesia is the future of anesthesia. It is also related to the concept of ERAS, enhanced recovery after surgery. The problem with opioid-free anesthesia is that intraoperatively you will perform opioid-free. It's possible, but when the patient is in a post-operative period, it's very difficult to control the whole of the picture unless you have some proposed plans like wound catheters and blocks. So otherwise, it will be a problem. That's an issue. Like for example, you are giving lidocaine infusion, for example, IV lidocaine infusion in post-operative period. It's difficult to control and manage because the toxicity can occur. So you have to be careful about these things. And unless it is not uh, commonly accepted, you cannot use the opioid-free strategies. Similarly, magnesium therapy, for example, use of this um, dexmedetomidine. Okay, so you can have more complications with hemodynamics with the dexmedetomidine. So that's some are the limitation of opioid-free anesthesia. So that's it. But otherwise, opioid-free anesthesia is a wonderful technique. A 31 years old woman with a history of acute intermittent. I will just show you what I have discussed. I will just show you the article for it. Just a minute. Because you will come here and you will go to pharmacology, and here you will find a lot of articles on opioids. Because opioids, a lot of points. This is what I was talking about, opioid-free anesthesia. So the concept is because of the complications and enhanced recovery. Okay, and the medications which are being used is alpha-2 agonist, lidocaine, ketamine, magnesium, beta blocker. How? Because they will blunt the response to the pain. Okay, to the sympathetic response to the pain. Gabapentin, it has opiate sparing, regional anesthesia. So the advantage is that because can someone tell me what is difference between respiratory failure? For question for noon, what is difference between respiratory failure and respiratory depression? Yes, noon.
Sir, if the respiration drops because of involvement of central nervous system, then it would be respiratory depression.
Okay.
And if the following, hello,
Again, please.
sir, sorry,
Noon.
actually I'm in theater, sir.
No problem. No problem. Be a little loud. We can hear you.
Sir, if the respiratory depression is the one which involves the central nervous system at the level of midbrain,
Okay. And what is respiratory failure?
and respiratory failure, the patient thrives, wait, sir. Yes, sir.
Actually, which is big? Who is father? Who is son?
Sir,
Respiratory failure is father,
respi-
or respiratory depression is father?
the respiratory depression, sir.
No. Let me explain. Actually, respiratory failure is the, you can say, the result. The reason, one of the reason of respiratory failure is respiratory depression. Because respiratory depression means that usually when there is anything which is increasing the respiratory response, like hypoxia will increase in respiration, hypercarbia should increase the respiration. So anything which is blocking this response, like which occurs with opioids, which occur with benzodiazepine, this is called as respiratory depression. Okay, and respiratory failure because of anything, because upper respiratory failure, lower respiratory tract problem, so anything which is leading to failure of the respiratory system is respiratory failure. So respiratory depression is one of the reason of respiratory failure. Okay, if there is upper airway
Sir, it
obstruction.
means respiratory
Sorry,
failure leads to respiratory depression.
sorry, again please.
Respiratory failure leads to respiratory depression.
No. It's different. I will repeat again. Respiratory depression is the response of any stimulus which will increase the respiration or response to the stimulus for respiration. Okay, the respiratory center. So if they are not responding in the way they should, this is respiratory depression. And respiratory failure is because of the mechanism failure, like upper airway obstruction. There is a respiratory failure. Lower airway obstruction, bronchospasm, aspiration. This will lead to respiratory failure. Okay, so this is difference between respiratory failure and respiratory depression. That's
Okay,
it.
sir.
I
Thank you, sir.
hope you understand. So, anyways, these are advantages of opioid-free anesthesia, and disadvantages, as I told you, that familiarity, patient characteristic, and it is not freely acceptable. So that's the reason. Uh, Otherwise, I still believe that opioid-free anesthesia is future. And the other thing which you should be knowing about the different receptors. What is concept of opioid naive? Can anyone know about it? These are the concepts they can ask you. Opioid naive is the person who has not never received any opioids. So that is the opioid naive. Then this concept of this various opioids interconversions. Okay. So you should be knowing IV versus subcutaneous or oral. this transdermal or oral. So intramuscular. So these are the things which you should be knowing. And then opioid dependent patient, and this one who the patients who are on opioid withdrawal treatment. So methadone and buprenorphine and this naltrexone. These are the patients who are uh, on opioid withdrawal treatment. Okay, so that's that's you can see here in the opioid folder. Okay, so let's go to the next MCQ. There is a 31-year-old woman with a history of acute intermittent porphyria. Presents with severe abdominal pain. She is tachycardic, hypertensive, and vomiting. A diagnosis of small bowel obstruction is made, and she is going to the theater for a laparotomy. Which of the uh, which of the following is the best option for her post-operative analgesia? Epidural, epidural with the levobupropion and fentanyl, because I think this question is on that the drugs which are safe in porphyria. Okay, so we will just have a look on it. I think levobupropion or fentanyl, one of them is not safe. Ketamine is also not safe. Oxycodone, wound infiltration with levobupropion. Let's see. I think the this question is on this basis. Okay. So porphyria encompasses a collection of inherited disorders of heme synthesis. Okay. There is one globin, which is of amino acids, and one is heme. So heme is a key constituent of hemoglobin and an example of a naturally occurring porphyrin. Its synthetic pathway consists of series of enzyme-dependent steps. Genetic mutation causes a deficit of a particular enzyme in this pathway, results in accumulation of the intermediate substrate that rely on it for their metabolism. Okay, so that's a problem in porphyria, that it's an inherited disorder of heme synthesis, and when there is any enzymatic absence or deficiency, so it will result in the accumulation of intermediate substrate that rely on its metabolism, not on it for their metabolism. A primary step on in the heme synthesis pathway is a combination of glycine and succinyl CoA to form compound this 5-ALA by the action of ALA synthase. Deficiency of any enzyme downstream from this step will cause the accumulation of 5-ALA. In all acute porphyrias, 5-ALA levels are elevated. So this is MCQ point you should be knowing which is the culprit enzyme and what is the
Porphyria.
Me.
okay. Whether this itself is the cause of clinical manifestation of acute porphyria is unclear. In any form of acute porphyria, acute neurovisceral crisis may be triggered by anything that increases the demand for heme, including infection, dehydration, starvation, and drugs. The key presenting features are abdominal pain, neurological symptoms, and tachycardia. As these are rather non-specific presentation, diagnosis is often made late. In this scenario, it is not a surgical condition causing the patient's pain, but this may additionally triggers a porphyric crisis. So, a number of drugs which is common in anesthesia practice may be unsafe for use in patients with porphyria. So, ketamine and thiopentone both are unsafe. Sevoflurane is unsafe. Levobupropion and ropivacaine is unclassified, so may not be safe. Among the analgesic, oxycodone and diclofenac is unsafe. Vasopressors, ephedrine is unsafe. So these are the list which you should be knowing. Okay, so morphine is safe, effective, titratable drug that can be used in porphyria and would be the drug of choice. The patient is tachycardic with small bowel obstruction, likely to be hypovolemic. This would preclude the use of an epidural. I think they are and levobupropion has indeterminate safety profile, so should be avoided. And relying on the local infiltration of surgical wound would not provide lasting analgesia. Oxycodone and ketamine are unsafe. So actually, you can have an article here. I will show you. Porphyria. So these are some of the, they can ask you in MCQ about which actually the types which are acute is these are the one. AIP, VP, there are different names about it. So acute intermittent porphyria actually is the one which is more serious. So they can ask you about these things, that fasting, dehydration, infection, drugs, endogenous hormones, stress, smoking, alcohol, they can trigger. Okay. And among the drugs, I think they will show here. So this is undetermined and unsafe. This is a long list, but you just have, the way is that which is safe. Propofol is safe. So you will use the safe one. So sevoflurane is not safe. So you go for isoflurane or desflurane. Even nitrous can be used. Bupivacaine is safe. Levobupivacaine and ropivacaine cannot be used because it's undetermined. Okay, lidocaine is also safe. Similarly, muscle relaxants are safe. Okay, neostigmine are safe. Among the analgesics, you have to just see that oxycodone, diclofenac, Onstan, and this pentazocine is not safe. Okay, so similarly, antibiotics, rifampicin, because commonly we don't use it, so antibiotics are common. Ephedrine, so you just have to, uh, ephedrine and vasopressin are not safe. Rest of these, you see, common medication, steroids, dexamethasone, hydrocortisone, not safe, not clearly safe. So these are some, even for revision for me as well, because sometimes we are using it and we don't remember. So common medication, you should not forget about the medication which we use commonly: sevoflurane, ketamine. Okay, because thiopentone and etomidate we don't use frequently. Even in our practice, levobupivacaine and ropivacaine is not available for the practical purposes. And then diclofenac, okay, oxycodone is also not commonly available. And then among the intraoperatively, don't forget about ephedrine, and then dexamethasone and hydrocortisone. So these are the things which you should be knowing. Okay. Mm, okay. So this is the key for, I think, have a high index of substitution is patient with unexplained abdominal pain. Send urine protected from light for PBG uh, monitoring. I think this is the PBG. What is meant by PBG? This is PBG, PBG, PBG will, the word PBG will come here. Anyone remember what is PBG? Anyways, don't waste time for it. So I will just, so I think this is some product, some among the, this, which is raised. And then remove or treat triggering factors. Give IV heme arginate, 3 milligram per kg, daily for 4 days. Avoid a catabolic state. May require large doses of morphine to control pain. Antiemetics like chlorpromazine and ondansetron are safe. Control tachycardia and hypertension with beta blockers. Seizure may be avoided by correcting hyponatremia and treating with gabapentin and this capra. Sedation with propofol and fentanyl is safe. So these are the things, because usually we don't read this topic frequently. So we should have a look at it. Okay. By PBG. Now this PBG is sticking in my mind. So actually, I have not read this topic very keenly. So this is PBG, porphobilinogen. Porphobilinogen is PBG. Okay. So AIP, this These are variegate porphyria, hereditary coproporphyria, and PBG. Anyways, so you can review here. So abdominal pain, cardiovascular signs, weakness, and psychiatric features, pain and sensory disturbances, seizure. So these are the things which can occur. Hyponatremia and other electrolyte imbalance. Yes, porphobilinogen assay is a laboratory test used to measure the level of a compound involved in Hep B cancer. Thank you. Okay. So let's go to the next question. Okay. So that's the reason oxycodone is not safe, ketamine is not safe, and levobupropion and fentanyl are undeterminate. And anyways, so let's go to the next question. 32-year-old man undergoing emergency surgery under GA for penetrating eye injury. Okay, so whenever penetrating eye injury comes in your mind, you should be thinking about full stomach, problems with the ICP, airway management, okay, and associated trauma. Never forget to think about associated trauma. So these are the things which you should be knowing. During the procedure, the surgeon palpates a globe and tells you that the IOP is too high. Which of the following measures is least likely to reduce the IOP? Okay. So they are just um, asking about this question of IOP. So you should be knowing, by the way, what factors increase IOP. That should be that the thing which are increasing the CO2, the thing which increase the ICP usually can increase the IOP. Succinylcholine can increase IOP. And then
Sir,
any
pathologically, glaucoma is a disease which increases
yes,
intraocular pressure. Then
yes,
open globe injury itself, it causes raised intraocular pressure. Then it could be because of raised intracranial pressure.
okay. So we can just quickly revise what are the factors which increase the IUP. Mm, So actually, the question here is on that which thing increasing minute ventilation will decrease. Acetazolamide should also decrease. Mannitol should also decrease. I think Trendelenburg position will increase. I think that should be the answer. Let's see what is the answer. Okay, so I was right. So Trendelenburg. So during surgery, control of IOP is important to prevent expulsion of contents of orbit. Okay, episcleral venous pressure is influenced by CVP is the most important factor determining IOP acutely. Hence, measures to prevent venous congestion must be applied, like taping or not tying, and an endotracheal tube, keeping the head in neutral position, reverse Trendelenburg with head up, avoiding cuffing by ensuring adequate muscle relaxation. Hypercarbia can lead an increase in IOP. So minute ventilation increase will help. Acetazolamide, mannitol can be used to reduce carbonic anhydrase inhibitor that reduce the production of aqueous humor. While mannitol dehydrates the eye by its action as an osmotic diuretic. By the way, can mannitol cause pulmonary edema? And if yes, why? It's causing volume depletion. So why it cause pulmonary edema? Yes, noon or wajiha.
Sir, I don't know the exact, but I read in a book in a Morgan. Sir, I wish. So उसमें पढ़ा
The
था in
holy.
that book के
No, no,
it
please,
causes
please, please,
mannitol causes pulmonary
please.
congestion.
First of all, please don't say
Yes, sir.
it
Yes, sir.
Morgan, the holy book of anesthesia,
The
the
holy
Morgan
book
Sharif.
of So I
Yes.
read there. That's why I'm mentioning that link, that point as only. Sir, is causes respiratory congestion. This mannitol. Uh,
No, no, no. It does not cause respiratory congestion. Yes, Vajiha, would you like to speak out? How mannitol can cause pulmonary edema? Actually, it's a heavy matter, heavy compound. Okay, so it withdraws water from the cells and keep it intravascular. Okay, so when the volume is increased transiently, it can cause pulmonary edema. Okay, so that's the mechanism. And
okay,
then
sir.
all of these things will go in the kidneys, and in the kidney it will pass through the glomeruli, and then it will attract more and more water. So that's the mechanism. Okay, so but transiently it can cause pulmonary edema because initially it will increase the volume, in not extra cellular volume. Yes, sorry. Okay, fine. Expansion of intravascular volume, to be exactly. It's not extracellular volume. Expansion of intravascular volume. Okay. So intravascular volume is increased and intracellular volume is decreased. So you are right, particularly, but even it is pulling out water from the interstitial space as well. Okay. That's why it's being used as osmotic diuresis. Okay, so Trendelenburg position as head down position will reduce venous drainage from the orbit and cause an increase in CVP and therefore IOP. Okay, so that's what is written here. And even here, so what are they have written? Parasympathomimetics contract the ciliary body and increase aqueous drainage, therefore through the trabecular network. Sympathomimetics, epinephrine reduces aqueous humor production and increased drainage, and possibly through the ciliary body vasoconstriction and adenylate cyclase inhibition. Beta antagonist, timolol reduces aqueous humor production through adenylate cyclase inhibition, prostaglandin analogs, and increase aqueous humor drainage via uveosacral route. So these are the different strategies, and I think it should also be known that what factors will the factors which is increasing the cerebral blood flow, which will also increase the intraocular pressure. Okay, so you can have a look on this article, and I think there will be some more options here as well. Mm, Actually, this source is very nice. This one, which I am just trying to show here, regional anesthesia. Just a second, please. So, okay. So IUP increased by opioids and induction agents, and these are the things. And increase IOP with ketamine, suxamethonium, metoclopramide. Metoclopramide, how it increase? I don't remember. Benzodiazepine and anticholinergics, they don't have effect. I don't remember how metoclopramide increase the IOP. It's interesting. Okay, so we'll go back to the next question. Okay, a 71-year-old man is undergoing a bilateral iliofemoral bypass graft with the aid of a cell salvage device. The surgeons have completed the right iliofemoral bypass and are preparing to be being operated. And on the left side, when you notice that the blood returning to the patient from cell salvage device is 1900 ml. After sending a clot sample to the lab, what is the most appropriate next step in management of the patient's blood loss? Blood returned to the patient from the cell salvage device is 1900 ml. I don't understand the question. Anyway, await the lab result and treat the coagulation accordingly. Request cryoprecipitate and platelets from the blood bank. Administer 1 gram of tranexamic acid. Use hypotensive anesthesia to decrease further blood loss. Check the patient's activated clotting time. This is a difficult question. Any ideas with the aid of a cell salvage device? I don't understand exactly what they are asking because they say that the blood returned to the patient from the cell salvage device is 1900 ml. So actually, it means 2 liter is coming back. So it is a massive blood loss which the patient has because these are in this one you in cell salvage actually only RBCs are coming. There is no clotting factors. There is no platelets. It's purely only packed cell volume. So this is a sign that there will be chances of clotting problems. So let's see which, because activated clotting time, I don't think so it will help. Use hypotensive anesthesia. No, I don't think so. Administer 1 gram of this may be one option, but this is too much bleeding. And I think this should be the answer. Await the lab result. No, you have to do something. So I think, let's see the answer. So it is, so cell salvage, actually the mechanism of cell salvage is that it is a clean suction pathway, and there are some contraindication or relative contraindication with the like carcinoma, okay, amniotic fluid and fecal matter is absolute contraindication. And the other thing which you can, because there are filters which can filter the this amniotic fluid or this one cancer. So for amniotic fluid, actually, there may be two suctions. One is suctioning the liquor, and the other can be used for the blood. But this is how it works. And there is a system of filtering, and then it clean, and then it redirects. So here, in the scenario, if 2 liter is coming, so it is massive blood loss. So cell salvage is a process of utilizing a patient's own blood retrieved from the surgical field to produce autologously transfused blood by filtering and washing it. Okay. Cell salvage therefore returns red cells and reduces the requirement of allogenic transfusions from the other patient. So, with the following indications, expected blood loss of more than 20% blood volume or more than 1 liter operations with expected blood transfusion requirement, pro-hemorrhagic states, preoperative anemia, rare blood groups, patient with rare blood antibodies, patient refusal for allogenic blood transfusion, because some of the Jehovah's Witness they accept their own blood. Some they don't accept. Jehovah's Witness are people who don't accept blood transfusions. So they have not written here because maybe it is one of them. You can say as cell salvage only returned RBCs. Okay, other blood products such as plasma, inflammatory mediators, more importantly, platelets and clotting factors are therefore discarded. Okay, so that's a key. Patient requiring more than 2 liter of autologous red cells are at significant risk of developing coagulopathy. Okay. In this clinical scenario, the patient is likely to require coagulopathic support due to anticipated further bleeding in the form of platelets and cryoprecipitate. Tranexamic acid useful in reducing ongoing bleeding as an antifibrinolytic, but it will not prevent the massive blood loss, uh, coagulopathy expected. So that's the reason. Hypotensive anesthesia is not recommended anesthetic technique in vascular surgery, carries a high significant hazard of complication in high-risk patient undergoing vascular intervention. Point of care measurement like ACT and intraoperative heparin therapy, but will not assess the treatment of massive hemorrhage going coagulopathy. Finally, the waiting for laboratory result will merely delay the required intervention of administering clotting products in a timely manner. Thus, requesting clotting products is the most appropriate step at this point, as it prepares anesthetic for the ensuing coagulopathy. So actually, this is the article which I can just show you here, cell salvage. You can read some more if you want. So this is actually the this mind map actually. Just a second. Salvage. This is an article on cell salvage. This is purely on the obstetric one, as I told you. And there are actually all the information is the same. Just what is the name of this article which they have written? Perioperative cell salvage. Actually, searching from it is a little irritating, but if you just learn it, then it becomes very easy. Okay, so because it will be in blood somewhere. So if you go to blood, you will find here in the blood transfusion separately. This is the article which is, they have even given the reference about it. Okay, so advantages, disadvantages, different use. Cancer, I told you, cell salvage is not recommended by the manufacturers in patients undergoing surgery for malignancy because of the possibility of reinfusion of tumor cell. But there are some filters by which they can use it. Use of for urological malignancy approved by NICE. So it's a controversial thing, but as I told you that this topic can come in even in the oral part, and the MCQs can come. Okay, so you can have a look here. So I think this is the same picture which they have showed in the other as well. So this is from the patient. So then filtering, reservoir, saline wash, processing, waste is here, and then it is going back and be transfused here. So it's a very simple schematic picture. So even there is an article on tranexamic acid. Noon, are you here? What is the mechanism of action of tranexamic acid?
Sir, sorry, sir. दोबारा sir, tranexamic
Tranexamic,
acid, sir.
tranexamic acid mechanism of action. Your holy book of Morgan does not tell anything about tranexamic acid. Actually, Wajiha, are you alive? Would you like to speak out, Wajiha?
Yes, sir.
But you
I'm
have,
listening to the meeting.
but you have to speak out. What is mechanism of action of tranexamic acid?
Sir, I was busy, but I was listening. But mechanism of action of
Tranexamic acid, the
transaminase,
darling
sir,
of
it's antifibrinolytic.
but how it works? What do you mean by antifibrinolytic?
Sir, it's antifibrinolytic.
Don't remember.
Sir,
Actually,
it
the
breaks down.
fibrinolytics.
It halts the process of fibrinolysis.
But how, my dear sister? This even the technician knows. You are the consultant anesthetist to be, inshallah, you have to tell the mechanism. Actually, there is
Sir,
a,
tranexamic acid,
yes,
antifibrinolytic agent, sir, which inhibits this plasmin.
plasminogen to plasmin conversion. Okay. It
Yes,
inhibits
sir.
the conversion of plasminogen to plasmin. So that is the enzyme which is converting plasminogen to plasmin is inhibited. Okay. And that's how it works. So you can find an article on tranexamic acid as well about their problems. One thing, remember one thing, that tranexamic acid, if complication, if they ask about complication, it can cause transient blindness because it inhibits the removal of the microthrombi which are normally cleared by the fibrinolytic system, and it can cause, you see, thromboembolic phenomenon. So because retinal arteries, they are tiny vessels, so actually the patients who are undergoing prone surgery, who have some baseline retinopathy, and now they are in prone position, they are getting hypotensive anesthesia, and then top of it, you are giving tranexamic acid. So this can lead to a serious problem. So that's why it is said that always try to better to give in infusion rather than bolus, because it will not block the bleeding. Okay, it has a you can say slow and steady wins the race like mechanism. So it's always better to give in a small infusion in infusion form rather than stat bolus. Okay, so if you want to have some more information about it, you can see here tranexamic acid. And actually the one mechanism is to go to the art to the tutorial, sorry, to the folder, or you can write here in like search. So you will also find either with the abbreviation or with the article name. Okay, so that's how. Uh, what else they said? Hypotensive anesthesia should be knowing what is the limitation, how to do perform hypotensive anesthesia, how to monitor hypotensive anesthesia. Similarly, they use the word of point of care testing. So point of care testing, one is ACT, even there is bedside INR. There is a machine which can measure bedside INR. Then this thromboelastography and TEG. Okay, these are all which can be used for the assessment and the need for the coagulation products. Okay, so a 67-year-old man is admitted to the emergency with a sudden onset of chest pain and breathlessness. Okay, so his ECG showing ST elevation in 1 AVL V2 to V6. So it's anterolateral. Am I right? So which vessel it will be? Left anterior descending. I always forget the blood vessel. Left coronary artery, because it is not only uh, sudden occlusion of major coronary arteries is the most common cause of MI. The area of myocardial ischemia depends on the coronary circulation. Early recognition of acute coronary obstruction and quick reperfusion is essential for a good outcome. Good anatomical knowledge. The blood to heart is mainly by right and left coronary artery. Right coronary artery from right anterior coronary sinus supplies blood to the right side of the heart. However, the RC also gives twigs to the right atrium and left ventricle. Okay. Right coronary artery travels along the right AV groove on its way to the crux of the heart. It gives off right marginal artery, which descends along the acute margin of heart and gives branches to the both sides of right ventricle. RCA continues to the diaphragmatic surface of the heart alongside the posterior longitudinal sulcus to continue to the apex of heart as PDA, posterior descending artery. PDA supplies the inferior and posterior wall of the left ventricle. LCA arises from the left anterior aortic sinus. It supplies blood to the left side of the heart, and it is larger than RCA. It usually runs for 1 to 25 mm as the left main coronary artery before bifurcating into LAD and left circumflex. LAD runs in the interventricular groove along the anterior surface of the heart. It gives diagonal branches, supply the anterolateral surface. So LAD, I was saying LAD, they are saying left coronary, I think because of lateral involvement as well. Okay, so it gives off and septal branches supply the interventricular septum on its way towards the apex of heart. LCX, left circumflex, primarily supplies the lateral wall of the heart, left circumflex. Okay, it runs along the left AV groove, reaches as far as the posterior longitudinal sulcus. It gives 1 to 3 marginal branches which supply the lateral free wall of the left ventricle. The coronary artery dominance is by the right coronary from the PDA, and in 85% is from right coronary. Okay, gives off PDA, and the coronary circulation can be identified as right dominant. In left dominant, it will arrive PDA is given off by the left circumflex, which is branch of left coronary. As the changes in ECG adjacent to the ischemic area usually affects the areas of coronary artery occluded. So that's how they will tell. Septal, because here it was anterior and lateral. So it is left circumflex and LAD. So that's why they are saying left coronary. Just a second. Condition. The patient has occlusion of left coronary artery, anterolateral and AVL. This lesion results in rapid deterioration of the patient condition because it usually leads to entire LV infarction. These patients have a poor prognosis if not treated immediately. So you can say it is the whole of the left coronary artery supply. So you can see the picture here as well, that this is left coronary, and it is supplying the LA, that circumflex, LAD. Okay, left marginal diagonal, PDA usually from the right coronary artery. So this is area, whole of the area supplied by the left coronary artery is involved here, anterior and lateral wall. So this is the anterior wall and this is the lateral wall. Unfortunately, this coronary supplies are very volatile. I have read so many times. So I was saying this left coronary is left anterior descending, but because it is involving whole of the area, so it is the more appropriate answer is left coronary artery rather than LAD, because it's involving the both the vessels, both the vessel area. Okay. 7-year-old boy. This is for Glasgow Coma scale. On assessing his opens to painful, so that I think E2, okay, cries to pain and withdraws from a painful stimulus. So what will be withdraws? So withdrawal is the second last one, flexion and then withdrawal. So let's see. It should be E2 and verbal cries to pain. So I think it also 2. So motor is 3. I think this should be the answer. Let's see. Motor is 4. Verbal is 3. Okay, so here it is opening to pain, so it is 2. And is cries to pain, so it is 3. And it is withdraws to pain. So flexion is 3 and withdrawal. This actually we do it practically, but it again it's something which you can err, like I have heard. So EMV, so is to, if it is opening or spontaneous, it is 4 with verbal and pain. So pain is the second last one, so it is 2. Here it is opening, warbling, responding, irritable and cries to pain, moans to pain, and none. So if it is responding to the pain, it's cries to pain, you can say. And if even it is not responding much to the pain, it is 2. And with motor response, no response or extensor and flexor. This is extensor response and then flexor response, withdraws to pain, withdraws to touch, and spontaneous movement. Actually, this question comes a number of times. Similarly, you should be knowing how to calculate the APGAR score. This is also very confusing. A number of times you can easily do. It's a very simple, it's not difficult, but you can easily do a mistake. So similarly here, so it is it's responding, opening eye to pain, cries to pain, and withdraws from a painful stimulus. So you should be knowing how to. So it's the answer, this one, the A1. One more question and then we will finish. You are called to urgently assess 54-year-old man in outpatient clinic who has acutely deteriorated following administration of oral antibiotics. So this is anaphylaxis. On assessment, heart rate is 145, low blood pressure, low saturation, wheezy. So what would you do? So first thing will be epinephrine. So here the answer question is revolving how much should be the dose. Should we give intramuscular or IV? First this question. According to the this local anesthesia, anaphylaxis guideline, it is intramuscular. Okay, so I think this should be the answer. Let's see. This is the answer. Okay, and I will just quickly tell you actually how do you calculate this 1 in 1000 means. Noon, you know about it? What is 1 in 100,000, 10,000, or 1 in 100,000? You know about it? The undiluted is 1 milligram per ml is actually 1 in 1000. Okay. So if you want to calculate in microgram per ml, so you just what you have to do, you have to cut these 3 zeros and take the remaining one and divide 1000 by it. Okay. So here it is 1, so it is 1000 microgram per ml, because 1000 divided by 1 is 1000. Then 1000 divided by 10 is 100 mics per ml. Okay. And this one is 10 mics per ml. And actually the preparation which we have with local anesthetic is around 1 in 200,000. So here you will cut these 3, so remaining is 200. So you will divide 1000 divided by 200. So that will be 5 mics per ml. So you should be knowing about it. Okay. So 1 in 1000 mean undiluted. Once you dilute 1, it is 1 in 10,000. Then the next is, if you dilute further, so this is 1000 microgram per ml, this is 100 mics per ml, this is 10 mics per ml. And if you make it even further diluted, you can make it 5 mics per ml. So the answer for it is actually intramuscular. And what are the rest of the things? Anaphylactic reaction, sulfurexime, epinephrine is the most appropriate drug. And then what they have said, IgE mediated reaction by acting beta receptors on mast cells. Okay. Intramuscular route is most appropriate for adrenaline. ECG monitoring is not immediately available, patient being on the ward. There is a greater margin of safety required in a suspected case of anaphylaxis. Repeated intramuscular injection can be administered according to the patient response. So it is the dose 0.5 ml, undiluted, 1 in 1000. That's 500 mics. And I think it's 10 mics per kg in pediatrics, if I'm not wrong. Just reconfirm about it. The administration has vast experience of using this route for adrenaline administration and excluding cardiac arrest scenarios. The patient is under full monitoring. When we are giving IV route, administrator has vast experience of using this route of epinephrine, and patient is under full monitoring because it can cause arrhythmia. There is no doubt regarding the diagnosis. So these are the points which is leading towards the IV. So in the resuscitation guideline, it's intramuscular. Though I don't actually I don't believe in it, but I don't know how they have made the guidelines. So because we have to follow the guidelines blindly, unfortunately, because we don't do any research by ourselves. Okay. So thank you very much. Inshallah, we will continue. I think we have finished this paper also. So congratulations. Thank you very much for your presence. Inshallah, we will continue. So please try to read the question which we have discussed. So the anaphylaxis you should read. Okay, the Glasgow Coma Score revise. AVPU also revised. Coronary supply. This should be your task. Okay. What are the point of care testing? Read about hypotensive anesthesia. Read about tranexamic acid. Read about some points about this thromboelastography and TEG and ROTAM. Okay. And then the factors affecting intraocular pressure, the anesthetic factors and the other factors. Okay. And then we read about a few words about this opioid-free anesthesia. Okay. And porphyria. So many topics we discuss in this almost 1 hour discussion. So thank you very much. And I know that I am just touching and going but actually I'm just giving you an idea how to how to target these MCQs. Okay. So thank you all of you for your time, precious time, and special thanks to Noon and Wajiha and Jennifer also.
Thank you so much, sir.
These days, Dr. Sajjad is also honoring me, and anesthetist is our I forgot your name, anesthetist. Dr. Waqar, are you Waqar Dehri? Are you Dr. Waqar Dehri? Please just let me know. Dr. Nahala, thanks, special thanks for you as well. Okay, thank you very much. Bye bye.
Thank you.
Pardeep, yes, yes. Sorry, I forgot your name, by the way.